Next up, we have Erin Davis, this time going back to the Faculty of Health.
Yeah. Do we take this off?
Erin's topic is a care practice bundle for nurses who support adults with cognitive impairment displaying challenging behaviour in hospital, a pre-post study. Okay, thanks a lot, Erin.
Hi everyone, thank you so much. I'm also not off script. I'm, unlike many of you, not from a teaching background, so speaking in front of people probably doesn't come as naturally to me as many of you in the room. My background is I'm a registered nurse. So I was working within a northern New South Wales local health district. I'm also a nursing lecturer and PhD candidate at Southern Cross University, which is very convenient. I actually first presented at Praxis 2 years ago when I was kind of at the start of my PhD journey. I just received word that my literature review was going to be published. And now coming back 2 years later, I'm running towards the finish line, the end is in sight. And I'll be presenting another one of the papers as part of my thesis. So I am doing my thesis by publication, which I'm finding to be an enjoyable experience, but obviously everyone's got a bit of a different journey, and we'll wait and see at the end whether I say the same. So over the past 18 months, I have been working with my amazing PhD supervisors, who are both on faculty here. Associate Professor Christina Agar, who's a nurse, and Associate Professor Michelle Bissett, who is the head of occupational therapy here. And we've been doing a multi-method study, a multi-site research project, exploring the barriers and enablers to nurse-led non-pharmacological interventions for adults with cognitive impairment who display challenging behaviours in the hospital setting. Big mouthful. So yes, today I'm going to be sharing some of my quantitative findings from that study. So as you can see, the title is a care practice bundle for nurses to support adults with cognitive impairment displaying challenging behaviours in hospital. It's currently under review for publication in Nursing Open, which is a Q1 journal. I'm also going to be presenting this paper at the Declared conference in Cairns next month, which is put on by the Australasian Delirium Association. So I'm using today as a little bit of a practice run, so I really welcome any feedback and questions that you guys have to help me kind of, perfect this for next month. Next slide, let's kick it off. Thank you. Oh, I have a buzzer. Where is it? Oh, here we go. I'm in control. Good, I like that. So, first of all, to understand the need for improved care practice, which is what my talk is all about, we need to recognise the growing prevalence and impact of cognitive impairment in hospitals. So in this study, we focused on dementia and delirium in particular as forms of cognitive impairment. They're two of the most common forms in older adults, so that's our main population we're working with. Both are they're rapidly increasing alongside Australia's ageing population, and that's a global trend that we're seeing. When adults with cognitive impairment are admitted to hospital, it's really important that we provide good care to them because they're actually at an increased risk of lots of different complications, so falls, infections, pressure injuries. They have a higher mortality rate. They also have a higher instance of being admitted into residential aged care facilities early. These outcomes aren't inevitable from a hospital admission. They're often linked to how our care is delivered. So nursing care can be a really key contributor to poor or good outcomes, particularly when we see challenging behaviours occur, which I'll explain next. So these behaviours that I'm talking about, I'm not sure if you guys have ever have a loved one who's had dementia or delirium. They can often present as aggression, agitation, sometimes apathy as well, refusal of care. And that the presence of these behaviours, it's really important that we understand that they're not just doing it to be difficult or challenging, but there's actually a reason behind it. So I like to draw on two complementary theories, and I use that as the theoretical underpinning for my nursing care as well as my thesis. So first of all, we have Cohen-Mansfield model of unmet needs, and that proposes that behaviours often occur when individuals attempt to meet their physical, emotional, or social needs but are unable to do so. So it's particularly relevant to adults with cognitive impairment. These needs often go unrecognised and unsupported, and that then leads to the behaviour. So it's a cry for help. It's the person's way of trying to communicate their needs. So for example, a person may refuse care, not just because they're being resistive, but because they're actually in pain or they're frightened or confused, and they can't find another way to express or resolve their discomfort. This intersects with the Hall and Buckwalter's progressively lowered stress threshold, and that explains that people with cognitive impairment actually have a biological reduced ability to cope with stress. Would we be able to go down on my script a little bit, please? And obviously hospital environments can be incredibly stressful. So they're busy, they're loud, the lights are poor, often people's sleep schedules get thrown out, and that's really exacerbatory to people with cognitive impairment. So they get overwhelmed, and that stress can then trigger behaviours like wandering around, pacing, shouting out, physical resistance often. These theories inform the development and implementation of the intervention behind our project, and we're trying to shift nurses' thinking. So we're trying to get nurses to understand these theories behind the behaviours. So rather than viewing behaviours as something to just manage or fix, the intervention was designed to help nurses identify and respond to unmet needs, reduce environmental stresses, and provide person-centred, non-pharmacological care. So that includes strategies that do not involve medication, so we don't want to sedate or give antipsychotics, but it's meaningful activities such as sensory stimulation, environmental adjustments, promoting familiarity, and that's to uphold each individual's dignity and well-being. This shift in perspective is particularly important as current hospital practice still often rely on physical and chemical restraints. So this is commonly used in many different groups within the hospital, but particularly adults with these kind of behaviours associated with cognitive impairment. We see that happening quite often. Both of those, they're linked to higher rates of morbidity and mortality, unlike the non-pharmacological approaches that we're supporting that have a very low risk. In fact, no risk in most cases. The barriers to these non-pharmacological interventions that nurses often cite, and this is really well identified in the literature, is they have a lack of time and staffing. They have limited resources, they don't feel supported, they have inadequate training, they don't really know what they're meant to be doing, so they rely on medications and restraints. And unfortunately, they also have negative attitudes towards adults with cognitive impairment. They express doubts regarding the efficacy of non-pharmacological interventions. They just simply don't think they work. So this brings me to the intervention, the solution perhaps. A multifaceted care practice bundle co-designed by the North New South Wales local health districts, and that includes a framework that categorises our behaviour of the patient from mild confusion to severe agitation and provides recommendations for person-centred non-pharmacological interventions. And that framework actually aligned with current existing policies and procedures as well, so it was fairly easily implementable. We also gave nurses a 30-minute face-to-face education session, and that was delivered by members of the research team, senior nurses, using a standardised PowerPoint and script. This was delivered over 13 wards, over 9 hospitals, so it was quite a large cohort. Lots of driving between different sites for myself. And the education sessions covered underlying causes of behaviour and also incorporated realistic hospital-based case studies so they could kind of see how it would work in real life. And then, of course, we had to provide non-pharmacological resources, which is the fun bit, I think. So this is fidget mats and fidget boards, which are essentially lap blankets with zips and buttons and colourful ribbons and things like that, that would often keep people's hands busy, which is a very common behaviour we hear in hospital, is fidgeting, pulling at lines and things like that. So those resources were funded by the district. There was quite a large grant received, and it was assembled by local community groups, which was really great as well, bringing the community into those projects. So, oops, I forgot to keep clicking. There we go. Perfect. So unlike previous research in this area that usually just focuses on education-only initiatives, we wanted to enhance nursing care practice, and we knew that the multifaceted nature of the bundle was more likely to kind of overcome all those dynamic barriers that nurses described and really help to embed true practice change across time. Rather than just dropping off an initiative and running, we really wanted to make sure that we saw a change and a shift in culture. So evaluation. To evaluate effectiveness of the bundle, we adapted a validated tool by some other researchers, Heinen and et al. This is a 20-question survey split across 2 different subscales. And it was asking nurses lots of questions in regards to their responses to challenging behaviours and things that they do as an alternative approach to physical restraint. So within each of these subscales, there were 7 thematic factors, which included things such as reacting with care and use of professional knowledge, and they kind of themed the underlying questions. Nurses across, like I said, 13 wards, 9 hospital sites, they did the education, but before they did the education, they were asked to do this survey. So that's how we got a fairly good participation rate, because the education was delivered during mandatory in-service time. So of course it was voluntary, but what else were they going to do? They were there anyway. So that was really great for us. Very captive audience, much like today, thank you very much. So once education was delivered, we achieved a 68% saturation rate across all of the sites, which was really great, taking into account a lot of the nurses on these wards worked on weekends, did night shift, annual leave, maternity leave is a big one. So we were aiming for 80%, but we happily settled at 68% across the sites. 6 months later, the nurses were invited via email to complete the same survey again. So it was the same population group, and then we did pre and post response matching using a unique identifier code. So that was the first letter of their mum's maiden name and the last 4 numbers of their mobile number. So it was something they could remember, hopefully, although there was some that didn't come through correct. So this is where I taught myself how to do statistics using textbooks and ChatGPT, and then had that validated with a biostatistician at QCIF. So once the survey data was completed, I did the analysis. The first question representing negative care practice, such as let me explain this. Some of the questions were reverse scored. So for example, if nurses were to say, I use sedation as an alternative to physical restraint, we obviously don't want them to answer yes often on that. So we reverse phrase scored those questions for them. So ideally they'd be answering, no, I don't often. We then used descriptive statistics to report demographic information and summarise the pre-post intervention responses, and we drew the mean and the median out of that. To assess changes in response, we used Wilcoxon matched pair signed rank test, and we set the significance level at the standard p-value of 0.05. So we had a pretty good response rate in the end. Of our initial 200 plus surveys, with the follow-up, we got 62 matched pre-post surveys, so I'm glad we allowed ourselves quite a big window for people not to follow up, and they were all included in the analysis. So the results beneficially showed improvements across all of the factors that we were looking at, and several of the factors were quite statistically significant. And those ones are highlighted on the slide, and I'm running on track. Specifically, so looking at this slide here, so following the implementation of the care practice bundles, nurses reported that were more likely to react with care and less likely to react by ignoring when patients displayed challenging behaviours. Beautiful, we love that. Examples of reacting with care meant that nurses were more often to organise activities for the patient. It also meant that they were asking the patients what was wrong and trying to find out what was underlying these kind of behaviours that they were seeing. As an alternative to physical restraints, nurses were more likely to use their professional knowledge and problem-solving skills. So examples of this were that they would make the physical care environment safer so that patients could walk around with less risk. It also meant that they were organising expert consultation with clinical nurses, with doctors, geriatricians, things like that. And they were less likely to administer medications, which was really great finding. Would we be able to scroll down a little bit, please? Oh, good. So these findings suggest the bundle did have a positive and meaningful impact on nursing practice. Gone too far, back we go. 2 key areas were discussed. So first, the multifaceted approach of the bundle appears to have contributed to the improvement. So like I was saying, not just doing the education, but also providing the framework and the resources seemed to be a really good thing to do. And that supports the growing body of literature suggesting that these kind of multi-component approaches are more effective in complex health care settings, such as acute and subacute wards. Second, improved responses to adults with cognitive impairment displaying those challenging behaviours indicate enhancements to underlying nursing attitudes and confidence, which is a really important finding because you might remember, as I said at the start of the presentation, often we find that nurses have prejudicial attitudes towards this population group. So by providing those resources to support better care practice, we actually found a shift in the attitude. And that actually aligns with some previous research as well that found correlation between attitudes, confidence, and care practice. Before concluding, I will acknowledge 2 key limitations of our study. Nothing's perfect. The survey's initial subscale demonstrated a low internal reliability, and that may impact the validity of some of the findings. That limitation was noted in previous studies that used the same tool, and it suggests that there needs to be ongoing refinement of that. And second, the study was conducted within a single health district, so even though we did it over 9 hospitals, it was all northern New South Wales, and that may limit the generalisability of results to other healthcare systems. So despite the limitations, back to the happy story, our findings indicate that the implementation of care practice can enhance nurses' attitudes and confidence, and it supports a shift towards person-centred care, which we talk a lot about in healthcare, and it aligns more closely with international and best practice recommendations. So looking ahead, the last step is we did a longitudinal qualitative study as well. So we went back again 6 months after that last survey, interviewed nurses, did some focus groups, and then another year after that, so it's been going on forever, it feels, went back again, did some more interviews. That data has been analysed, and I'm in the middle of writing up the paper at the moment with the assistance of my supervisors, hoping to have that submitted by the end of next month. So we'll have some really great qual data to support our findings. That's it.
Oh, thank you, Erin. That's fantastic. I really like, in particular, 2 aspects. One, the non-pharmacological intervention of it, and B, the focus not so much on challenging behaviours as a problem to be managed in the workforce, but rather as a quality of care issue for the patients themselves. So excellent. And I look forward to seeing some more of those papers coming out of that as well.
Hopefully.
Any questions for Erin from the audience? Thor.
Thanks, Erin, for the fabulous presentation and very important work.
Thank you.
This might be a divergence, but I know a lot of individuals who are at home, and do you think that your work could potentially translate to home care?
That's actually a really good question. So what I would like to do post-doc, because I'm already there in my head, is actually work with carers on discharge so that we can take some of these strategies home, because one of the things we see happening a lot is people with this kind of cognitive impairment being admitted to hospital because their carer has acopia, so they're not coping at home. So I would really love to work with those carers and give them some strategies to try and support them through these difficult behaviours. So great question.
That's a nice sounding postdoc too, Erin.
Yeah, always 10 steps ahead in my head. Still got to do this first.
You seem well organised. and someone with a background in experimental psychology. I do like the method too.
That's great. A fantastic presentation. Thanks so much for that. I was really keen to know if something like those blankets are available so that you can buy them to take home for your family that has dementia and things like that.
Another good question, thank you. So they actually are available online, but they're prohibitively expensive. So the reason I started this research was because I was actually making them for my patients in the hospital to gift the patients to take home. I've made about 350 to 500 of these blankets and started a community sewing group where we sent them out to aged care facilities around Australia. So this is how I got into researching, so finding something that I was passionate about and kind of pulling at that thread. So they're not currently available, but what we do is anyone that's admitted to hospital, we make sure the family or the aged care facility know that that is to go home with that person. So my dream is we start seeing them filter through the health district organically, just from people coming back into the hospital. And then potentially, because they are quite expensive to make and sewing's a bit of a lost art form, potentially I would like to kind of run some programs again where we're able to make them and donate them to different healthcare facilities.
All right, well, thanks again, Erin. And look, I'm sure if there are any other questions from the audience, Erin would be more than happy to chat with you.
Always happy to have a chat.
Yeah, for sure. All right, so we're up to our...